in the eye can lead to high pressures, and it has been seen that overall at 10 to 20% of cases you have uveitis, they can have glaucoma at some stage during their course. The presentations could be varied. They can come as acute, and when glaucoma in uveitis presents acute, it is usually because of inflammation of the trabecular meshwork, but it could be for many other reasons. You can have an obstruction with acute inflammatory material, or sometimes there could be a secondary angle closure glaucoma because of the ciliary body fusion. So it's very important to know right in the beginning what is causing the acute rise in pressure, because that will determine the treatment. Because the treatment for trabeculitis and angle closure, because the secondary angle closure due to UV fusion would be different. So that has to be kept in mind. And then you can have a chronic presentation, which again is usually because of some structural alteration at the angle due to cynical angle closure, or there could be a fibrovascular component like you get a neovascular disease, or scarring, obliteration of the meshwork. But sometimes, and quite often actually, it is also because of the steroid induced, because steroids are the mainstay of treatment for uveitis. So sometimes it might be very hard to differentiate what you are dealing with, whether it is steroid-induced glaucoma or a chronically elevated IOP because of damage to the trabecular meshwork. So you have to be careful and keep that in mind. So the goal of treatment for glaucoma and uveitis basically is, number one, to minimize the permanent structural damage to the trabecular meshwork, but because that will go, otherwise that will go to a chronic stage. So we want to treat uveitis as soon as possible and as effectively as possible. And also, from glaucoma point of view, we have to protect the optic nerve so that the visual function is maintained. So what we can do is there are a number of options. There's no one therapy which will work for all the patients. Sometimes just observation will be good enough. If the pressure is not too high, if you have a situation like partial Schlossman syndrome, which is self-limiting, maybe you may not have to do much. Most of the time you will need a medical therapy, which is the preferred therapy. Occasionally you will need lasers, especially if there's a iris Bombay formation because of the synecdoche. There's a pupillary block and you need to relieve that block, so you would need some kind of laser there. And sometimes you would, when nothing works, you will need surgery. So I'll just show you a couple of cases. This case is a 32-year-old female, came to us with a high pressure, like 56 millimeters of mercury, acute presentation again, was diagnosed like a partial Schlossman, elsewhere and treated with topical steroid, oral, as well as systemic anti-glaucoma medicines. But on careful examination, we found that there are multiple. You can see there are very large KPs and there are multiple on the cornea. So this is something a little unusual for partial Schlossman to have that big mutton fat KPs. So we found out that patient actually had a sarcoidosis. So that actually alters the diagnosis. So this is not really a partial Schlossman. It may be much more than that, and you would need a therapy here. So with the treatment, the pressures came down. The vision was still low on the right side, but the IOP was 8 millimeters of mercury with the medical treatment. And if you look at the angles, you can see there are multiple synechia already forming. That means there's already a structural damage already happening. So that also indicates this is not the first episode. Probably this patient had certain episode in the past, and they were kind of either treated or resolved spontaneously. At 2 weeks, the pressure was 12 millimeters mercury with anti-glaucoma treatment. So the response was very good to medical treatment, and the pressure was normal. But that is also deceptive sometimes in uveitis patients. So you need to follow it up, and sometimes all you need to do is basically to treat the acute cause and then follow up the patients, because the synecdoche, there's a structural damage to the angle. So this patient can have more episodes of uveitis and also later on have chronic uveitis. So that needs more careful monitoring. So this was simple in that sense that at this stage it was.
Pandav, can you tell them what medicines we cannot use in cases of uveitis?
Yeah, basically they need to be, they need to follow very carefully and find out what is the cause of the uveitis in acute, what is the underlying cause which needs to be treated. So here the sarcoidosis needs to be treated, and because just controlling glaucoma doesn't end the story. Another case is a 35-year-old female, granular metauveitis, and had high pressures for about 2 months. And you can see there was some peripheral anterior synecdoche already visible here, and we also had some large granulomatous KPs again. And in this case, the disc is already damaged, showing a glaucoma change. And if you do the fluorescein angiography, you have some kind of vasculitis and occlusion of the retinal veins. So again, the gonioscopy, look, there's a structural damage is much more here. You can see there's some neovascular membrane already forming and multiple synechias, much more than what we saw in the past. And this change suggests that IOP has been high for a very long time. So this has already gone into a chronic stage, and you have the neovascularization to the angle already. So basically, we treat this eye again with the ocular and systemic antihypertensive, to reduce the pressure, and also to treat the underlying pathology, because here the pathology in the posterior segment. So she needed injection, Avastin, scatter laser, steroid, and of course the systemic as well as topical antihypertensives, which controlled her pressure. And this is the follow-up picture. We already have done the laser, and the old KPs are still visible, but they are no more fresh. And gonioscopy, you can see this. The membrane has disappeared, that there's no NVA now, but the synechia which has already formed because the previous inflammation, they're still there, and the IOP is still like 34 millimeters of mercury, is not being controlled. So this patient would need surgery, and what surgery you want to do, that again could be debated, because uveitis is not a very good, is not associated with good surgical outcomes, but one can start with trabeculectomy with mitomycin C, or you can do something different. This is another case. Now, you can see here the 27-year-old male diagnosed case of tuberculosis. Patient of tuberculosis and now has uveitis. He has undergone multiple surgeries already, vitreous hemorrhage, partial vitrectomy done. And on presentation, the vision is low in the right eye, and pressure is high in the right eye on systemic medication, as well as topical anti-glaucoma medicine. Now, this patient actually needs filtering surgery. It also needs cataract surgery. So, again, one can debate whether we want to combine trab with phaco or with a tube with phaco. Now the problem is that here the uveitis is active, there's a cataract, all these surgeries have been done. So this is not a simple case for trabeculectomy or phaco, so it will need much more aggressive treatment. So we did a phaco and AGV. So we basically put a tube along with phaco after 1 month of control of inflammation under cover of steroids, and after 1 year the pressures are quite well controlled. The vision is still low because of the posterior segment pathology, but otherwise the pressures are well controlled with the single drug. So that's kind of a good outcome with the tube. In this patient we did a primary tube and cataract surgery at the same time, so that gives a quick visual rehabilitation as well as some IOP control. This is another case. 8 years old. Now you can see this is juvenile rheumatoid arthritis, and they are really difficult to manage. This patient has already undergone multiple procedures: phaco, cataract surgery, cyclitic membrane remover, vitrectomy, steroid injection into the eye, and the pressures are like 30s and 40s with all anti-glaucoma medications, systemic as well as topic. So here we did a tube implant for this girl, and this is because these are complicated eyes and they're actually quite sick eyes. So whatever you do, I mean, because you don't have many chances here. Trabeculectomy could have been done, but in this particular eye, which is already so sick, the chances of TRAF success are very low. And even with the TRAF, we ended up with some complications. We had hyphema, but fortunately that recovered without any intervention. And we have, after about a year, we had a good outcome. Vision is still low, but at least in pressure terms, the outcome is not bad. Now, 6 millimeters of pressure is actually low, and I would be concerned because these eyes have a tendency to go for hypertony. So this is another case with the diabetes.
Dr. Pandav?
Yeah, okay, so I'll wind up.
Let us get on to some of the very basic questions what a general ophthalmologist would like to know from you. And
okay,
the first is, what are the topical medications that you will not like them to use in cases of uveitis?
So basically, I think the anti-glaucoma medicines you have to use, because there's no one therapy for all, but you have to avoid which can induce uveitis, like prostaglandins you probably would be avoiding, and you can very well use like timolol, you can, or beta blockers, you can use alpha agonists as well as carbonic anhydrase inhibitors. And more often, you might need systemic therapy in the acute phase, especially. And if you need to do surgery, then again, the choice is you can have a tube or you can have a filtering surgery like trabeculectomy with some adjuvant, because the chances of failure for surgery in these eyes is quite high. So you have to modify your treatment. They need quite aggressive glaucoma surgery if it comes to that. So it's better to treat the primary condition first adequately and promptly so that you don't reach that stage.
Second thing, Dr. Pandav, if the patient is not getting controlled on anything and he has active uveitis, so we have no choice really. So can we do a trab?
I think if your disc is really at danger, sometimes the pressures could go like 50s and 60s, and nothing is working, then you could do a trabeculectomy because you want to save the eye.
Yes. So
eye,
what
yes.
special precautions in that trab would you like to take? Would you like to increase the mitomycin time, or would you like the oral steroids to be given
Probably
together?
I will not increase the mitomycin C, but more importantly, I will control the inflammation as far as possible even before surgery. And there you can actually talk to the people who are managing the uveitis, or even to the internist, because we often manage this with the help of the internist, who can give you non-steroidal anti-inflammatory, like other immunosuppressive drugs, which can be helpful in controlling the inflammation. So sometimes steroids are not able to control inflammation, then you have to give immunosuppression therapy in other form. But make sure that the eye is quiet before surgery.
Can you tell me the role of NSAID, to topical NSAID? In
I think in a severe, if you have ocular hypertension response and your uveitis is not much, you can try them. But once the uveitis is active, it usually doesn't respond very well to those drugs. So to conclude, glaucoma is often associated with uveitis, and the presentation could be quite variable. The response to treatment is variable. Differentiation between steroid response and inflammation could be tricky, but it should be tried. And therapy has to be tailored to the need of the patient. There's no one thing which will work for every patient, so you have to be careful with what drugs you use and what surgery you use. Thank you so much.